Hello, everyone. Thank you for joining us for the third installment of the Root Cause Coalition's 2017 webinar series. Before we get started, I wanted to run through a few features of our webinar today. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of the webinar, our panelists will be answering audience questions. If you have a question during the webinar, please type your question into the question pane on the webinar control panel located at the right side of your screen. This webinar is being recorded and will be available for download on the Root Cause Coalition website later this week. Thank you all again for attending, and at this time, I'm going to turn it over to our presenters.
Good afternoon. I'm David Waters, the CEO of Community Servings, and I'm excited to be presenting with my colleague from Nonprofit Finance Fund, Bill Pinakiewicz, on food as medicine, the role of medically tailored home-delivered meals in holistic, patient-centered models of care and systems change. Next slide. My own experience in this field as the CEO of Community Servings, I've been in the field of food and nutrition for 25 years and have been the CEO of Community Servings for the past 18, 19 years. I'll be explaining more about what we do in the course of the presentation. Bill?
Yeah, I'm Bill Pinakiewicz. I'm a Vice President at Nonprofit Finance Fund. We'll be telling you more about Nonprofit Finance Fund later in the webinar, where David is going to talk at a very micro level about community servings and medically tailored meals and the partnerships associated with them. I'm going to be addressing more at the macro systems level about those medically tailored meal partnerships and the considerations and possibilities that we at NFF see in that. I'll tell you, we've been a strategic financial management partner of community servings for the last 2 years, and I spend about 80% of my professional time these days working in that space where health through community-based organizations that deal with SDOH intersects with healthcare, and that's again what this is all about. So looking forward to it.
Thanks, Bill. So as Bill said, we're going to start with the micro, which is to look at the specific intervention at the community level and at the healthcare setting level. And then we will look at some of the research, and then Bill will step in and take us to some of the larger macro policy implications for healthcare and social determinants of health. So to start, Community Servings is a nonprofit food and nutrition program based in Boston, Massachusetts, feeding 20 cities across Massachusetts and soon expanding in Rhode Island. Our mission is to provide medically tailored meals and nutrition services to homebound individuals and their families coping with critical and chronic illnesses. We often use the term food as medicine, and it's used in a variety of different ways around the country. But here it's meant to be a very focused application of specifically the provision of medically tailored meals and nutrition counseling to those in the community who are struggling with critical and chronic illnesses. So certainly we are an anti-hunger program, but even more so, we are a healthcare intervention providing controlled diets to people who struggle to control them on their own. It starts with food insecurity, but it expands to inability to cook, and even more so, inability to manage complex medical diets and often multiple diets on your own. Next slide. Community Servings history, like most medically tailored meals programs, grew out of the HIV community and the HIV crisis in the late 80s and 90s. We were founded in 1990 in Boston to feed 2 neighborhoods of Boston. And what's interesting about HIV in the context of nutrition is that in the early years before the first drugs came along, majority of people were actually dying from AIDS wasting syndrome, which is essentially your body attacking its own muscle tissue, burning muscle tissue, the HIV virus. So we figured out that if you could feed people, you could keep them alive longer while we were waiting for the first medical and pharmaceutical interventions. So we think of it as the first example of food as medicine. And programs like us grew up in urban areas where there were significant HIV and AIDS populations. And still to this day, many of the largest programs are in those large urban communities. Here in Boston, we started feeding 30 people a day, delivering hot meals to people in 2 neighborhoods living with the virus. And about 15 years ago, expanded to feed people with any critical or chronic illness. And we now serve about 1,850 people in 20 cities across Massachusetts. Next slide. We are, as I said, part of a national movement. We call it the Food is Medicine Coalition. It's all programs like community servings that are providing these kinds of services in major metropolitan areas primarily. So New York City, Philadelphia, Atlanta, Washington, D.C., Baltimore, San Francisco, L.A., Denver, Minneapolis, etc. Locally, we are the only program in the 6 New England states, and while we are proud to serve 300 square miles of New England, there is tremendous need, and we are about to expand into our neighboring state of Rhode Island. The Food is Medicine Coalition is both a training and TA services group, but even more so, it's an advocacy and research group. So when we are doing research in any of these individual programs, we are sharing that with each other, and we do national advocacy work like congressional briefings, etc. You can check out Food is Medicine Coalition via the coalition's website. Next slide. Here at home, Community Servings provides meals to folks dealing with 35 different primary illnesses. The top 4 are HIV, cancer, kidney disease, and diabetes. If you counted diabetes as a secondary diagnosis, it would be our largest population, which probably wouldn't be a surprise to anyone in the healthcare world. What's most interesting is that 71% of our patients are dealing with more than one illness. So they might have been living with HIV for a long time, but they have since developed heart disease, or they're having type 2 diabetes, but that has led to kidney failure or breast cancer issues, etc. And we are not a poverty-based program, but 92% of our patients are living below 150% of the federal poverty level. Next slide. What Community Servings offers and medically tailored meals programs offer generally is a range of medical diets. In our case, we offer 17 different medical diets every day. Renal diets for kidney failure, controlling potassium levels, diabetic diets, low vitamin K diets if you're on a blood thinner because of blood clots, etc., food allergies, etc. And most unique is that you can combine them in up to 3 different ways. So it's about 100 different nutritional plans that you could have. You can imagine that if you were lactose intolerant and diabetic and managing potassium levels for kidney disease, that could be completely overwhelming for someone who is very sick, doesn't feel like cooking, doesn't necessarily understand what foods have potassium or glucose in them, but also may not have food in their cupboards. That's the key to the intervention. It's also important that sick people don't necessarily have an appetite. So if we bring them institutional foods, what I call my high school cafeteria food, they're not going to eat it. So all of our food is made completely from scratch down to the soup stocks using local farm produce and culturally appropriate for the communities that we serve. Along with the food intervention, which is a weekly delivery of, in our case, lunch, dinner, and a snack for 5 days. Some of our sister programs do up to 21 meals a week, 3 meals, 7 days. But we also offer, and it's very important, wraparound services of nutrition counseling and disease-specific nutrition education. So your doctor's changing your meds, you've developed GI issues, we're able to work with you to change your diet to address that, or perhaps you've lost your appetite because of chemo treatments. We're able to show you how to take our meals and break them into more palatable, more appetizing, smaller size meals for you. And we also offer nausea care packages for people who aren't yet ready to graduate to solid foods. Next slide. So some of the important research around malnutrition that often surprises folks is that 1 in 3 patients in America enters the hospital malnourished. Their stay will be 3 times as long as those who are properly nourished, and their costs will be 3 times as high. So to the degree that we're able to address their malnutrition at home, we can have a significant impact on hospitalization rates, ER visits, healthcare costs, and of course, healthcare outcomes. Next slide. Some of the research that's being done by our sister programs around the country, MANA of Philadelphia recently did a study of their clients that were receiving medically tailored meals through an insurance plan, and the insurance plan saw a 50% drop in hospitalizations among this population and 20% lower healthcare costs than comparison groups. Similarly, a pilot study by Project Open Hand in San Francisco was feeding folks with both HIV and or type 2 diabetes for 6 months, saw a significant improvement in food security, nutritional health, mental health, behavioral health, dramatic improvements in depression, diabetes self-management, the difficult trade-off between food and healthcare, whether to feed or eat, and potentially significant improvements in glycemic control and reduced hospitalization rates and ER visits for their type 2 patients. Next slide. Again, here in Boston, our policy initiative involves reimbursement partners looking for health insurers, accountable care organizations, ACOs, or hospital systems that are interested in contracting with us to provide meals for some of their most expensive patients, working directly with healthcare leaders around research and policy and advocacy partners, which I will go into at the next slide. Community Servings has been working for about 3 years, reaching out to healthcare leaders to make the argument that it would make sense for them to hire us to feed people. Our funding model up until 3 years ago was based on philanthropy and government HIV contracts, but we carry a waiting list because we can't raise money fast enough through charity to feed all the people that are very, very sick and need our meals. So with the dawn of healthcare reform, we have been out there along with colleagues around the country making the argument for insurers that it's more than just the intuitive argument that if you feed a sick person, they're going to do better, but actually demonstrable results that we can justify contracts. So for Community Servings, that includes 2 contracts for a dual eligible demonstration project. It's called the One Care program in Massachusetts, a similar program for a large regional insurer neighborhood health plan for their highest utilizers of the plan's healthcare services, and a new PACE senior contract in Rhode Island. Each of these is paying us a weekly fee to be feeding their patients that are referred by their own doctors, care managers, and discharge planners. In Massachusetts, there is a new waiver that is requiring all Medicaid or what are called Mass Health patients to be part of an ACO. So there are about 6 new ACOs coming online in Massachusetts. We are in conversations with many of them to include our medically tailored meals as part of the wraparound community-based services for their patients in the ACO. Next slide. One of the most interesting patients that we serve is a patient of our insurance partner, Commonwealth Care Alliance. And this is information directly from the insurer about this anonymous patient, anonymous but real patient. Sarah is a 52-year-old woman. She's struggling with morbid obesity, pituitary dysfunction, type 2 diabetes, high blood pressure, chronic kidney disease, blindness, and a history of blood clots. She lives all alone in a one-bedroom apartment and takes 32 different medications, including a blood thinner. Now, Sarah has a very hard time standing or getting into the kitchen, but you can imagine the conundrum she would have if she was trying to design a meal that would address her diabetes, her kidney disease and potassium levels, concerns with blood clots, her lactose issues, etc. Community Servings is able to customize a meal for her that is low potassium, low vitamin K, not too many leafy greens, that is non-dairy, and low carbohydrate and diabetic. So in that way, we're customizing this meal in 4 different patterns to address Sarah's multiple medical needs. Next slide. Here in Boston, we're involved in 3 research projects at the moment. 1 is a clinical study and 2 are retrospective studies. We are partnering with a doctor at Mass General Hospital and affiliated with Harvard Medical School, Dr. Berkowitz. His field is the intersection of health and food insecurity. With Dr. Berkowitz, we are feeding patients with type 2 diabetes and an A1C level greater than 8, who have also, through surveys, been found to be food insecure. It's a relatively small study, 25 patients with 25 in a randomized control study, and we should have results in that clinical study in the next few weeks. We are also involved in 2 retrospective studies. One is our insurance patients through Commonwealth Care Alliance, funded by the AARP Foundation, where we're going to be analyzing the claims data for about 300 patients we've fed over the last 2 years versus 900 patients who were either receiving Meals on Wheels or receiving no nutrition supports at all. And those results should be coming in the fall. And most exciting is a new study funded by Robert Wood Johnson Foundation, which is looking at 3,000 people Community Servings has fed over the last 5 years versus 9,000 people that were not fed. In Massachusetts, we have access to what's called the All-Payer Claims Database, and partnering as a co-investigator with the Department of Public Health and Mass General Hospital, we're able to access that claims data to look at hospitalization rates, ER visits, when they were discharged, were they discharged to home versus a clinical setting, and healthcare costs overall for the 3,000 folks we were feeding. It's a Robert Wood Johnson funded study. It'll be 30 months, and we should have results in the spring of 2019. Next slide. In all of our work, we are close partners with Root Cause Coalition and the Food is Medicine Coalition, but also very much in the last several years with Bill's team at the Nonprofit Finance Fund, as well as our close neighbors at Harvard Law School, the Center for Health Law and Policy Innovation, who have helped us to understand healthcare regulations, Medicaid regulations, the ACA, the AHCA, et cetera. And they're very important partners of ours. Next slide. For community servings and meals programs like ours, we are going to continue to focus on building the evidence base, really looking at an ROI. What's exciting about that, the potential for developing that ROI, is not just that there might be more meals provided by current providers and more people being fed, but an ROI that could be applied to any community across the country and develop new revenue sources to feed more low-income sick people who might not be able to access SNAP benefits, pantries, soup kitchens, et cetera. This will lead to increased referrals for more reimbursement partners. We are working on a statewide policy agenda and partnering with Congressman McGovern, who's one of the leaders nationally on food as medicine and anti-hunger issues, and continuing to engage with root causes, research, education, and advocacy subcommittees. And with that, I want to pass it over to Bill and NFF.
Thanks, David. David mentioned we've been a partner for several years now, and we really bring strategic financial management to the partnership. And I'd like to just take a minute here to give you what that means in terms of the lens that we look through and what informs our thinking when we look at something like these medically tailored meal partnerships and what the larger macro systemic issues are associated with it and the possibilities are. So for starters, with Nonprofit Finance Fund, we are a not-for-profit community development financial institution. Our vision there is that a world where capital and expertise come together to create a more just and vibrant society. Mission for us is unlocking the potential of mission-driven organizations through three areas: our tailored investments, which is our lending program. We've been a lender to community-based organizations and the broader social sector for over 36 years. I've been giving strategic advisory consulting services almost as long, and do a lot of publishing and surveys that we share on a knowledge-sharing basis with the field as well. And all that's guided by our core values of generosity of spirit, responsiveness, leading by doing, and rigor without attitude. So so that's the lens that we look through. This is what informs our view of these sorts of medically tailored meal partnerships, and more broadly, partnerships between community-based organizations dealing with the full range of social determinants of health and clinical care providers. So what's the overview and the framework from this systems level for these partnerships? Next slide, please. So it's a recognition of the high potential value proposition from the intersection of health and healthcare. And so even with this rapidly changing healthcare landscape, we believe the shift from volume to value-based payments remains at the heart of healthcare reform, but with an increased focus on costs, outcomes, and accountability. I'm going to use a couple of terms here. I just want to make sure I've got a definition of them for you. CBOs, community-based organizations, and we talk about healthcare systems, we're talking about hospitals, hospital systems, health plans, the full range of things on the clinical care side. So, but with deep connections to the communities they serve, we think CBOs are critical stakeholders with healthcare systems as they seek to improve the health and resiliency of low-income communities. But the CBOs themselves need knowledge, advice, and capital to adapt to this new landscape. And so we see key questions for capturing this high potential value proposition of the intersection between health and healthcare being the following. One, what capacities do nonprofit CBOs need to develop, and what investments do they need to make in order to be strong participating partners to lift up the health in the communities that they're a part of? How can philanthropy and other funders move investments to an outcomes-focused framework that creates more sustainable networks of local community-based support? And the third question here, which we're going to be talking about more, which is where do the boundaries of responsibility lie, as well as the shared responsibilities among community-based organizations, healthcare providers, public and private players, philanthropy, government, and impact investors in creating healthier communities. So given this high potential value proposition and these questions, a key driver in the systems level view of medically tailored meal partnerships is the following. Next slide, please. And that's building these sustainable partnerships between healthcare systems and CBOs providing SDOH. And here's the logic train that appears to be afoot to us as we do all of our work nationally in this space. So with the move to risk and value-based payment models, healthcare systems increasingly responsible for population health outcomes, still maintains. High need, high cost patients have a disproportionately high utilization rates and costs. Poor outcomes are invariably related to one or more unmet social determinant of health needs. And this, by the way, is information that is coming to us from the hospital systems themselves on this. So therefore, there is a need, a compelling need to match high need, high cost patients with social services that address their non-clinical SDOH needs. And that's a significant bottom line and population health issue for healthcare systems. Had an interesting observation made by a hospital executive on this point, saying he thinks we are in what he calls a Galileo moment. And what he meant by that was that sees hospitals not being the center of the universe anymore, but communities being the center of the healthcare universe, and bridging to communities being an imperative for him and his hospital system. And so that logic train and our recognition of this at NSF, we are working with and have had both hospital systems and CBOs and funders come to us to build the partnering capacities and to develop a scalable and replicable platform for sustainable partnerships to address and integrate the social determinants of health of these high need, high cost patients into the clinical care setting. And so in order to operationalize it, what the work that's afoot on this is to create tools and business services for both community-based organizations and the healthcare systems that can enable, inform, and help sustain those partnerships. And then so that's the big picture on this. So let's take it back for a second. How does this macro systems framework relate to a community servings, food as medicine coalition, and medically tailored meals? And there's the next slide. So I will confess this is my most least scientific slide I've ever made. And this is intended to convey a high concept that suggests sort of how things might play out in these partnerships of CBOs dealing with SDOH with healthcare systems. And so just start looking at the vertical axis, characterize that as the proximity of social determinants of health impacts to clinical care outcomes and cost, and they go from lower to higher. You look at that horizontal axis, those are the sort of listing of preventative programs from those that are far upstream to midstream to those that are downstream. And at the risk of creating all kinds of arguments, I decided to see if we could make a point about how this might play out by putting counseling on healthy foods and eating habits as a representative social determinants of health intervention that is fairly far upstream, down in that lower left-hand corner, and represented medically tailored meals as predominantly a downstream intervention up at the top end of that prevention to clinical care continuum. And what we think this suggests is the shorter time frames to impacts for medically tailored meals, for example, and other interventions that have a similar profile and characteristic, suggests that the higher near-term impact can facilitate the ability to show evidence on cost reduction and improvement in outcomes in clinical care, and can be done in a relatively short time frame. The suggestion, again, is here with further investment and capacity building that allows this whole notion to establish a beachhead that can drive social determinants of health-focused systems change by building out templates and frameworks for scalable and replicable sustainable partnerships and expanding reimbursement contracts with various and sundry payers. And then that can be leveraged by taking the best practices and and accelerating by the use of the templates, the adaptation and use of that down as you go down the continuum, so that things that are farther and farther on the upstream side of things can be brought into those partnerships as well. Interestingly, the other thing that this suggests is what Community Servings has done, is that the investment and the partnerships don't have to be singularly with a solely downstream, midstream, or upstream intervention. As David already mentioned, they combine as part of their intervention. They have both upstream and midstream services involving counseling and education, so that investment in medically tailored meals through the Community Servings model actually is an investment on the entire prevention continuum, which will encourage, we think, systems change as well. So that's the grand theory potentially of how change might occur to accelerate and bring more integration of SDOH into clinical care. But it raises the question, great theory, but is anybody really doing anything about this stuff? And so I ask you to go to the next slide, please. Next slide, please. Thank you. And so this is work that we're doing. That's the stuff that we know best. And the first is on capacity building initiatives, and to give you a feel for the kind of investment in capacity building that's already being made around that theory of change, if you will. The Kresge Foundation has the Healthy Outcomes Initiative that we are partnering on with them, a cohort-based capacity building that focuses on networks of providers, and the idea here is to build up understanding and readiness of those community-based organizations in those networks for a collaboration and partnership. And a lot of networks were assessed for participation in this. There are now 4 networks that we are working with. It's the Lutheran Services in America, CSH, the Greater Portland Addiction Coalition, and interestingly, the Food is Medicine Coalition. And CSH is the Corporation for Supportive Housing, and for those of you who don't know them, I would suggest that that by and large, these networks do somewhat represent what we've shown in that graph with the Food is Medicine Coalition. The second piece here is a Robert Wood Johnson Foundation-sponsored initiative that we at NFF are doing in partnership with the Center for Healthcare Strategies and the Alliance for Strong Families and Communities. And this is basically assessing a landscape of examples and lessons on partnership models between CBOs and healthcare organizations nationally across the field, and getting into a much smaller number that we look at from a case study perspective. And this is designed to increase dialogue, specifically with funders on successful partnership models. Interestingly, just to give you a sense for the kind of work that's out in the field on this, we sent out an RFI for those who are engaged in these kinds of partnerships to send back information about them for the potential to be included in case studies, etc. We got 217 responses to the RFI of examples of these partnership models between CBOs and healthcare organizations that are already out there in the field. And lastly, on the capacity building, again with Robert Wood Johnson Foundation, we investigated feasibility of launching and scaling community health funds, and identified a number of feasibility drivers, resource and investment needs, because the goal here again is not just to build the capacity of CBOs and healthcare organizations to participate in these partnerships, but to build partnerships that are financially sustainable as well. So that's the capacity building side. On the next slide are just some samples of investments. And we'll go through these very quickly. There's Health Right 360. You see on the right the I won't go through the sizes of these things. The more important aspect are the impacts, but better outcomes through the coordinated services for complex high-need clients available under one roof. LA Kitchen, infrastructure needed to successfully bid for senior congregate meals, contracts, job training, healthy food, and LA Family Housing, construction of this campus to provide a continuum of integrated housing, healthcare, and social services. The interesting aspect of the partnership component of this is that NFF led these investments, but had substantial co-investment from a co-investment partner, which was Dignity Health in both Health Right 360 and LA Family Housing. Another example of this notion of building capacity and making investments to accelerate the capacity of the system to support these sustainable partnerships. And we are also about to launch a California-based fund called AIM Healthy, between $10 and $20 million to invest in similar kinds of transactions. So the last thing I'll do on my last page here is to then say, what are the key takeaways then from this macro systems perspective and looking at the kinds of things that community servings is doing with medically tailored meal partnerships. So I'll quickly tick through them. So interventions like community servings, MTN, lie largely at the end of the prevention continuum where they can have high near-term impact on clinical care outcomes and costs as part of integrated care approaches. This can facilitate their ability to show impact evidence on triple aim objectives with high need, high cost patients in a relatively short time frame. Takeaway 3, with further investment in capacity building, this could well position medically tailored meals and other interventions at this end of the prevention continuum as the beachhead in driving social determinants of health focused systems change through these partnerships that are sustainable with healthcare systems and expanded contract for reimbursement of these services. And then the further system change could then be driven from this base and a strategy focused on leveraging the best practices established, accelerating the replicable and scalable templates, and adapting the approach for interventions across the full prevention continuum. And so when we look at this and our abiding interest and the partnership that we have with the community servings is that what it's doing on a micro level is something that we think has the capacity to be codified to a certain degree and adapted in other situations through replication and scaling in a way that can affect what we think could be very effective systems change, with the end result being a focus on and achieving better community health outcomes at lower costs. And I'll stop there.
Monique, before you open up for questions, I had two things to build on Bill's piece. One is that I didn't mention when we were talking about meals clients for community servings. Patients could be with us for 2 weeks if they were an end-of-life hospice patient, or 10 years if they had a long chronic illness and perhaps a disability on some of our insurance contracts. But the average stay on the meals program is 9 months. And so not as long as folks might think about healthcare, folks might think about when they're thinking about committing to feed a patient. And while 30% of our patients are seniors, which is what you might think of as a meals population through Meals on Wheels programs, the average age of a patient on a medically tailored meals program is 45. So folks who are very sick and very isolated with no support networks to care for them and may not qualify for lower level interventions like Meals on Wheels. And the second point is that community servings carries a waiting list of about 140, 150 patients at a time who could be on a waiting list for 3 to 6 months. They are very sick, in need of meals right away, but we don't currently have the revenue streams to feed them. So these exciting systemic changes or potential opportunities within healthcare reimbursement models is an opportunity for very sick patients to get fed a controlled diet that would improve outcomes, lower costs, reduce rehospitalization rates. And with that, I think, Monique, we can probably open it up for questions.
Great, thank you. If anyone of our participants have any questions for our panelists, feel free to type those in the question pane at this moment. Right now, we don't have any questions from anyone, so I'll give you a minute to type those questions in if you have any. And just a reminder to all of our participants that a recording of this presentation and the slide panels, or the slide deck, will be available on the Root Cause Coalition website later this week. I do have a question for you both from Enrique. He asks, is there a program like this in Chicago or Illinois in general, that you guys know of?
There is a program in Chicago called Vital Bridges, which is part of a federally qualified health center in Chicago. It had its roots in the HIV community. I think they do more medically tailored pantry bags than frozen meals per se. But you could look up Vital Bridges on the web to confirm that.
Great, thank you. Another question from John, directed at Bill. What are the size investments that the Nonprofit Finance Fund makes, high and low?
I'm sorry, what are the, I'm not sure I understand the.
I'm sorry, the size of investments.
Oh, size of.
Yeah.
We will, the sort of floor is about $500,000. The maximum investment is a function in some ways of how many co-investors we can bring to the table. So we've done, as you've seen in the listing here, some reasonably sizable transactions. And so I would say the top end of that is really a function of sort of the nature of the transaction and how much co-investment we might be able to bring to it. We have to get basically internal approvals to go above about a $3 million amount. So.
Great, thank you. What is the average cost per meal for the community servings medically tailored meals? This is a question from Aaron.
It's about, depends on how many meals you're providing, so it's difficult to set a price exactly. It involves counseling, it involves nutrition education. It really depends on how many wraparound services you're providing, but it's roughly in the range of $10 to $15 a meal. Depending on how many meals per day and how much mileage there is, how much counseling, et cetera.
Thank you. Another question by John. He asks, has there been any investigation into how medically tailored meals might work in rural areas?
It's a great question. You know, because this is a home delivered model, up until now it has primarily been focused on urban areas where there's a density of patients, but programs like community servings are being encouraged to look at statewide service when you start to talk about insurance contracts. And so there's a lot of work right now going on both inside the field and outside the field on delivery models. Amazon is doing some of that, et cetera. But I think looking at how to ship meals to rural partners and still have them high-quality, scratch-made meals that are medically tailored rather than some of the commercial products that are out there, which are highly processed, is a big focus of programs like ours right now.
Lynn asks, looking back at the beginning of your work in your organizations, what advice would you give to someone interested in starting a program like this in their community?
Well, the first is that's a big answer. That's a big question to answer on a webinar. I would recommend that the individual reach out to one of us directly. Our contact information is on the slides. But you know, it's the capacity to make high quality food where you really know what's in it, to partner with registered dietitians who can define medical diets and bring the level of customization that many patients need. You know, it's not that unusual to find a program that can offer a diabetic meal, for instance, as a relatively large population. But when you say that they also need to control potassium levels, et cetera, you can see that there are less and less programs available that can do that. So working with registered dietitians and understanding how to customize meals and maintain a high quality product is the first. And the second is identifying the right partners and referral partners, but also funding partners to get a program up.
David, it's Bill on this. On that question, I have a question to follow on that. Does the Food as Medicine Coalition provide support for folks who might be looking to do a startup organization of that sort, or is there contemplation that they might?
Yes, we are working on a concept to an accelerator that would allow us to both develop these confirmed funding streams, but then offer support for replication in other communities. So we definitely want to see more medically tailored meals programs come online. And so we'd love to hear from anyone interested in potentially moving into this realm.
Great, thank you. We have another question from JB. JB asks, what were the challenges working with health systems or providers, and how did you overcome those challenges?
Well, I think the broadest challenge, which has gotten a lot better over the years, is that health systems are scared of committing to feed a patient forever. And so years ago, we would get a lot of resistance when we would talk to healthcare leaders because they couldn't see how they could fund anti-hunger work. But when you talk about specific medical interventions that are time defined, that's easier for them. But I think they still need to understand what it is they're committing in terms of financial commitment, how long they're going to provide the service, and realize really why is it different than an anti-hunger or a Meals on Wheels intervention. So making those arguments, I think, is critical. And then once contracts are identified, it's about connecting on the direct service on the ground level with nurses and care managers to make the referrals for their patients. The first time they make a referral, they may be skeptical, but when they start to see the benefits to their patients, more referrals tend to ramp up and sort of flood in.
David, similarly with your conversations with ACOs, that same question, are there issues there that are ones that need to be ironed out that are worth mentioning?
Well, there's anytime you're administering a new contract, there are negotiations to go on both sides. How often is the delivery? What's the service area? How often do they get recertified? How often do they verify their insurance payments? Because patients come on and off insurers all the time. And what's the billing implications? So do you have software in your CBO to do direct bill to an insurance company? Do you need to have a Medicaid number yourself? Those kind of technical reimbursement model things. For most of our insurance contracts, we are doing a mix of online billing into their billing system and some still done through paper invoices.
Great. Another question from Renee. Renee asks, how is the nutritional counseling aspect of community servings program being offered? Is it provided face-to-face or by other means?
Yeah, some of our sister programs around the country do face-to-face. Virtually all of our nutrition counseling is done on the phone because our patients are generally homebound and they're not able to come see us, and we don't have the level of staffing where we could be sending people out into the field for nutrition counseling. So the patient can call us or we're calling them to check in. If they've missed a delivery, we may be checking in on them. If their paperwork needs to be recertified every 6 months, we're checking in with them, but they can also call us daily if they choose to talk about issues they're having or better understand what is the medical diet they're on, what the side effects of their drug regimens are, et cetera.
Great. On the Food is Medicine Coalition map that was that you presented, David, one of our participants asked what organization is in Florida. They're curious.
It's called the Poverello Center. I think it's in Fort Lauderdale. It's Poverello.
Great, thank you. Another question, going back to talking about ACOs, participant asks, directed at community servings, have you ever implemented this model with providers not in ACOs, or have they all been through ACOs?
Yes, they're not all ACOs. There are several managed care organizations or traditional insurers.
Great. Well, I think we have answered everybody's questions. Just a reminder that the recording of this presentation and the slide deck will be available on the Root Cause Coalition website. Yes, I think we're good with questions. So if you have any additional questions after this webinar is over, I would direct you to contact David or Bill directly. Their emails are listed on the screen now and will be available for download on the Root Cause Coalition website. I want to thank both of our presenters today and everyone for listening in. We hope you have a great rest of your day. And this concludes the third installment of the Root Cause Coalition's 2017 webinar series webinar. Thank you all. Have a great day.
Thanks, everybody.